joint. We're going to start moving down the arm now. And I'm going to tell you, the further we move down the arm, the more complicated kinesiology gets because of the number of pulleys and everything down in the hand. Elbow, simple. Wrist and hand, oh boy. So let's talk about elbow, wrist, and extension. We're going to talk about forearm pronation, supination, and then carrying angle. We're going to talk about all the three of those when we're going through here. So bony landmarks again. Scapula comes back into play because the biceps are going to attach onto the scapula, right? We have our long head attaching to the supraglenoid tubercle, right? We have the short head attaching to what? The what process? What does the short head of the biceps attach to? Yeah, good, okay. And then the infraglenoid tubercle is where one of the long heads of the triceps attaches, right? So that scapula still comes into play, even though we don't think about it a lot. And then we have that bone that's no longer funny to us anymore ever since we started studying it, the humerus, right? We have, when we get to the top of the humerus, which we're not going to deal with the elbow too much, this is up here where we have the head, the neck, and the surgical neck. But with the elbow, we're going to talk about this inferior, this distal portion, right? We have our trochlea. What does trochlea mean? Does anyone know what trochlea means? When I say this, that the actual look of the trochlea will make total sense to you now. So the trochlea is right here, right? Trochlea means spool of thread. Now do you see the spool of thread? Right? So we've got our trochlea. We got our capitulum. What does capitulum mean? Spindle works too, yep. What does capitulum mean? Because don't you have a capitate in the hand? All right, if I say you're doing capital extension, what are you extending? Capital extension is that final motion of head extension, right? So capitulum is the distal head of the humerus. Why do we call it the capitulum then? Well, because we already have a head. So we can't have the superior head and the inferior head, although some books do teach it that way, that there's a superior head and an inferior head. What they'll say is the superior portion is the head, the inferior portion is the capitulum. And if you look close enough at it, right, it kind of looks like a head, right? We can draw, there, it's a head. And then we've got thread going over this spool here. Mr. McKeever's drawing class. We have our lateral and medial epicondyles, right? Those are those pointy parts on the elbow that we can feel. And then we have our supracondylar ridges, right, which allow for our muscle attachment. And then we have my all-time favorite thing in the whole wide world, the olecranon fossa, right? The olecranon fossa is so that what can fit in there? The olecranon, right? Sorry, I just have way too much fun saying that. I love olecranon. So that's our humerus, and we're going to go down to our next biggest bone, which is our ulna, right? Our ulna has the olecranon process, which goes into the olecranon fossa. We have our trochlear notch. Gee, I wonder what's going to go in there. I mean, that's really hard to figure out, but I'm going to guess the trochlear notch is going to go around the trochlea. We have our radial notch. Gee, what do you think is going to sit right in there? The The humerus, exactly, right? The head of the radius. That's where that radial notch is going to be. Oh, God, we've got the coronoid process versus the coracoid process. That's where things get a little... when I was studying this stuff, that was where I started hating life. Where I was like, wait, you've got a coronoid and a coracoid? Oh, God, shoot me. Right? I always remembered that on the scapula, I had the coracoid. On the ulna, I've got the coronoid. I don't know if that helps anyone or not, but that's the way I remembered things, and that shows you just how my brain works. Because I was numb when I was studying this stuff. We have the ulnar tuberosity, and then when we get down here, we get that ulnar styloid process. And as the ulnar styloid process, the medial or lateral styloid process. Is ulnar medial or lateral? Good, it's medial, right? When you look at this, what does the styloid process look like very similar to somewhere else in the body? Where else do you have some little pointy thing that sticks out like that? Maybe on the tibia. Yeah, right? And here's the thing, in some other, like, again, when we get to other countries, right? This is the medial malleoli of the ulna. I don't know why we don't do stuff like that. We've got to separate it out. But it's the styloid process, right? And then we have the little bit of a head down here. The next thing we're going to get is the rad radius, right? And the reason it's rad is because it's on the thumb side, because you're a rad man. You've got the head, which interacts up here with that radial notch. You've got the radial tuberosity. And then you've got the radial styloid, which is your lateral styloid process. So at the elbow itself, we have all kinds of ligaments, and the ligaments make up the what of the elbow joint? The ligaments that hold it together make up the, what's that called? That holds the elbow together. The joint capsule. Good, Adrian. Good. Right, so those ligaments help make up that joint capsule. So if you look, we have a medial and lateral collateral ligament. Huh. That looks really familiar. It's almost like we have those at the knee. Right? At the radial ulnar joint, we also have the annular ligament and their interosseous membrane. Right? So looking at those, I believe I have pictures of them coming up here. So the medial collateral ligament's on the medial side. The lateral collateral ligament is on the lateral side, right? You have the annular ligament, which kind of holds everything nice and wrapped in place of that radial head, right? And then in between the two bones here, you have that interosseous membrane. And the interosseous membrane looks a lot like the interosseous membrane between the tib fib. Right? Keeps the bones from separating, provides more surface area for attachment of the muscles, the forearm, and the wrist, right? But if you look at it, when you actually look at the interosseous membrane, there are holes in it. What do you think those holes are for? Yeah, to allow nerves to pass through. Exactly. Nerves and some blood vessels. So that's pretty much it for the elbow. We get down to the wrist, things will get a little hinky. So muscles. All right. Where is my brachialis? Where's my brachialis at? under the biceps. So in here, right? Good. So that means this is going to be my biceps brachii. Then I've got my brachioradialis on my thumb side. Triceps. Where's my anconeus? And my pronator teres. Elbow, good, right? Where's pronator quadratus? That's probably the one that everyone messes up the most frequently. There's my brachialis, biceps brachii, brachioradio, triceps. There's anconeus, right? It attaches from my ulna up to my humerus. There's my pronator teres. This is, for some reason, this is the one that people forget about. The pronator quadratus, because they think that pronator quadratus is up here. I don't know why, but it is proximal to the wrist. Good. And the main reason I say that is that can be a real tender area for patients. I think Tyler could even attest to that, working with doing massage. That can be a real tender area for them. And that just working that can relieve a lot of wrist pain. And then we've got our supinator or a supinator. Gee, I wonder what its job could be, just like the pronators. Why can't they name all of our muscles that? Why couldn't they call like the biceps the elbow flexior? I just make things so much easier. The supinator. He jumps off the building and then splats. All right. So the elbow itself is uniaxial, so it only has 1 degree of freedom. It does flexion and it does extension. Right? This is a mistake the book makes. Or no, actually, they did right. I corrected it. It's right. The book says that the extension is a firm end feel. The extension is a hard or bony end feel. I did correct that. With flexion, it is a firm, but what else could it be? So going into flexion, it can be firm. What else could it be? Let's say you got a swole bro. And you flex up, they've got that huge bicep. It could be what type of an end feel? Soft end feel, right? So just because you have a soft end feel doesn't mean that there's a problem, right? And then you've got this, here's that proximal radial ulnar joint, distal radial ulnar joint, and here is the motion of the forearm. When you see this, to me, I don't know, like for some reason, when I see the way that we can do supination and pronation, looking at that really just makes me go, wow, we are designed for bones to cross over each other in the wrist. I don't know, that to me is amazing, right? Like we're designed for those bones to literally twist around each other, and they're hard surfaces. So going into palm down, you will get a hard or a bony end feel because you can feel it, it kind of locks in. You're at bone on bone at that point. Going into supination, now you've got them farther apart. Now you've got a firm end feel. So pronation is another area where you will have that bony end feel or the hard end feel. Carrying angle. The carrying angle is the distal end of the humerus not being level, right? So this is kind of what we're talking about with the carrying angle. It's about 5 degrees in men and 10 to 15 degrees in women. Why do you think that's different? What do you think has caused us? Okay, breasts, good. The shoulders, and there's one other reason. What have women traditionally done that men kind of shirked? Carrying what? Babies, right? Not saying that men's job is not to carry the babies. That's not what I'm saying. But based upon the carrying angle, I mean, guys, there you go. Just say, I'm sorry, I can't take care of the kid. My carrying angle is not as great as yours. I mean, if you really want to get smacked, use that. But it's a little different. And it makes sense, right? Because, you know, if you've got extra tissue here, that angle is going to have to be greater, right? And also, it increases the overall function of that so that you can carry baby for longer. This angle does affect strength, right? there, in the study I read last night, talked about the generational kind of idea of this carrying angle, and that it's designed men to lift stuff quicker and with more force, whereas it caused women to carry stuff for longer periods of time. So I don't know how much the study was interesting that they did on it. It was like a retroactive study of a bunch of stuff, but showed that, you know, men tend to have a little bit more initial force and can do things quicker, whereas ladies have the ability to carry things for longer periods of time. It is kind of interesting, right? And I guarantee if I talk to every guy in here right now, and I'm talking to all of you, and let's see, ladies, if you would agree with this with your significant others, or guys with your significant others, when unloading groceries from the car, a man will load every single possible thing they can into their arms and only make one trip if possible, even if that means breaking every bone in your arm and tearing every muscle in your arm. Yep, exactly, Jara. So Jesse agrees, Anthony agrees. And there's actually, believe it or not, there is some biological evidence to that, right? What would we have been carrying back to the cave or the campsite? Meat or firewood, right? And if we left some of it behind, that could mean that we don't eat for 3 days. So when a guy does that, just kind of laugh and realize that there was an evolutionary component to that. But I'm 100%, I'm one trick gang too. When I come in, I've got my cases of Coke spread on my fingers and the bags spread all the way out my arms. And then I get to the door going, oh, how do I open the door? I live alone. I'd rather die than make another trip. Exactly, especially in this heat, right? But there is some, there is some evolutionary reason for that. And if you look at it, it is traditionally guys. Now, it doesn't mean that women are immune to it. Evidently, Erica's got some evolutionary traits to her there. But it's funny, the other class, I asked that, and almost every single person's like, yep. I think in here we'd all agree, too. It is true. I don't know what it is, but it has something to do probably with the carrying angle. Just saying. So here's kind of a motion of supination and flexion combined with the bicep to open a ever important bottle of soda, right? That's what that is. It's a bottle of soda. And this can be problematic for some people. They may not be able to actually have you ever actually had that one friend that can't open the bottle of wine no matter what they do? Well, it has to do with the combination of both the supination, pronation, and elbow flexion. That's why they can't do it. They just don't have that ability to combine those motions to pull out that cork. So they make all kinds of new devices for that now. You have a little wine opener that pops the cork right out for you. I was fascinated when I was in Denmark that almost every family had a wine bottle opener on their counter. So it's kind of looking at the motions, right? So supinator is going to help with that supination as well as biceps. So let's talk about some common pathologies here. Lateral and medial epicondylitis. I would say that most of us have encountered this at some point in our life. Lateral epicondylitis is typically traditionally tennis elbow, and medial epicondylitis is golfer's elbow. I don't have an easy way of remembering that. The only way I ever remembered that medial versus lateral is that lateral has a T and tennis has a T. That was the only way I got it when I was coming through the program. But, whatever helps you remember it. But lateral is tennis elbow, right? And medial is golfer's elbow. I can't simulate golfing because I suck at it. Even mini golf. I'm horrible at mini golf. So those are two common. Elbow dislocations are common, and supracondylar fractures, right? So looking at this elbow, here we have that arthrokinematics going. Oh gosh, right? So we've got a little bit when the elbow's extending, we've got some posterior glide that's locking that olecranon in the olecranon fossa. And then when it's flexing, we've got anterior glide, right? And that's sliding that out of there to allow it to move. The radius and ulna slides slightly when we're doing any type of motion, right? When we're moving into flexion, you get an anterior glide of the radius on the ulna. And when you're moving into extension, you get a posterior glide of the radius on the ulna. So here's some problems. Got some serious problems going on with both of these. So on the left picture, what do we got here? Yeah, that's a dislocation, right? Now, the positive note for that person, when you look at that, is what? What could you give them as a positive with that dislocation? Nothing's broken, right? So that means typically, you know, we're going to pull that way and that way to get this little lip to come back over here. And once we get it there, it'll be popped right back into place, right? It's the good news. Bad news is you've probably torn a crap ton of ligaments, right? But the good news is overall, that's not surgical. Now over here, we got some major problems, right? That would be a supracondylar fracture. Supracondylar because it's above the condyles, right? And so that humerus is snapped clean off. When you think about it, also what's going to be another problem? Your biceps are now like that. And look right there. What's probably happening to the biceps? You got that nice sharp edge of that fracture. It's literally acting like a cheese grater on your biceps. Yeah. Right? So not only do you have the insult of having the fracture, but you've got this nice cheese grater surface right here that's digging into the biceps, the brachialis and all that are just literally shredding them apart. On a positive note for this, your triceps, they're pretty much okay, right? I think we might have another problem going on out here if you look. Do you see what I'm talking about out there? And you got space right there that's not supposed to be there. Yeah, we got a crack out there in the olecranon too. So this is definitely going to be some surgery. They're probably going to have to put a pin in there. They're going to have to relocate this back here and reapproximate it. So smooth off the surfaces, reapproximate it, and then put a plate and pins to hold that in place. That's not going to be a fun surgery. That patient is going to come out of that surgery with a lot of pain, right? And probably cast as well. So let's talk about lateral medial epicondylitis, because I didn't mention much in these slides. Medial and lateral epicondylitis are overuse injuries. When I say overuse injuries, what does that mean? Or repetitive strain injuries. Yeah, you've done the same motion over and over and over and over again. That's why a lot of times we'll call these tennis elbow and golfer's elbow. Because you got the tennis people constantly, I don't know, I think that's what tennis people do. Not sure. I think they go this way too. And then golfers, right, lining up, hold on, and coming through and getting a lot of force in that medial aspect of that elbow. And so you get epicondylitis. What treatments have you guys discussed for epicondylitis so far? What kind of stuff can you do for epicondylitis? Ultrasound, good. Ice massage is great for it, right? And I know we didn't get to do the massage class, which I'm very, very sad about. That's one of my favorite classes because we could have had Tyler help out as well with it. But the regular massage, a lot of cross friction on that will really it'll aggravate it, but it'll also help get some of that fibrous tissue kind of broken up that's causing it to get stuck. Because what's happening is those muscles are kind of sticking down to that lateral epicondyle. So now let's think about this for a second. We have medial and lateral epicondylitis, right? So one of those is going to be a flexor wad tendon problem. The other is going to be an extensor wad tendon problem. Which is which? Is your lateral aspect your extensors or your flexors? Feel it, right? Tennis is your extensors, right? Golfers is your flexors. That also includes of your fingers, right? So say I've got like tennis elbow, right? I don't have a hand, do I? No, I don't. You can have patients do things with their hands and still irritate that area and work it. Same thing with the reverse. You can have them squeeze stuff and you're still, I mean, just by doing that squeezing, you can see, right? My medial side is working. Both the medial and the lateral side have what's called wads, right? Have you guys talked about that in anatomy? Because you have your extensor wad and your flexor wad, right? And what that is all of those muscles kind of attach in the same place above that epicondyle and that part of the humerus, right? So your flexors and extensor wads, or you'll hear commonly, they'll say the patient's got extensor wad condylitis or flexor wad condylitis, just depending upon whether we're talking about tennis or golfer's elbow. I really don't like calling it tennis elbow and golfer's elbow. I'd rather call it what it is medial lateral epicondylitis. But still docs use that old tennis and golfer's elbow as well. Let's talk about open packed and closed packed. So open packed, again, is for mobilization. Closed pack is for stabilization. So closed packed, obviously for the elbow, is going to be full extension. There's no way I can mobilize that elbow when that olecranon is locked into the olecranon fossa. Can't do it. With open packed, you're going to be in about 70 degrees of flexion. So this is a big mistake. I see a lot of people mobilizing the elbow in this position here. This is only about how much degrees? This is how many degrees here? I'm at a right angle. I'm at 90 degrees of elbow flexion. I need to back out of that slightly, right? And then if you look, I'm also in 10 degrees of supination. My name is in the way? Oh, hold on. There. So this is where I see a lot of people mobilizing that elbow at, is at 90 degrees. You want to back out of that 90, get to about 70. And then you also want about 10 degrees of supination. I'm in full supination here. A lot of times what I'll say is you want to be kind of midway between pronation and supination. And that will help out. Now I can get in there and I can actually mobilize my own elbow pretty easy. And I can feel those ligaments stretching. But again, in that closed pack, you ain't mobilizing nothing. But in the closed pack, you have best access to your epicondyles. So when they're extended, it's a lot easier to do ultrasound on those epicondyles or ice massage on those epicondyles, right? So it still has some reason for it. With a capsular pattern, if the problem is the actual ligaments, you'll have greatest restriction in elbow flexion. So you'll have more problems bending the elbow than you will extending the elbow. Well, that makes sense because extension is just going to be allowing what to kick in? What pretty much allows you to extend your elbow? You don't have to fire a muscle. You can let what take over. Gravity. Yeah, gravity can do that for you, right? But if you're having some restrictions, a lot of times it's going to be more of the capsule than it is the actual biceps itself. With the forearm, there's not a hard rule about what that capsule up here, where that radial ulnar joint is. It can be both supination and pronation. So a lot of times when we have problems with supination and pronation, we're going to mobilize and exercise because we're not sure which is causing that loss of motion. Range of motion at the elbow. Full range of motion, full flexion is about 150 degrees. So let's see, 45, 90, right? About 135. I don't quite have 150, but about 150 is what we want. Your extension should be 0. Now we will run into people, excuse me, that have 5 degrees, 10 degrees. We had one student in cohort 5 that had 25 degrees of hyperextension. Right? Yeah, that elbow basically bent backwards. Does that mean you're weird? Probably. But some of you guys will have a little bit of hyperextension in the elbow, and that's just, it could be from playing sports, could be for any number of reasons. Maybe your mom, you inked on your arm too much as a kid, who knows? Pronation, supination, equal 80 degrees. That makes it easy to remember those. Let's talk goniometry of the elbow, right? What do you think is going to be my fulcrum that I measure off of? So my midpoint. What's a good pointy part on the outside of my elbow? The lateral epicondyle. You got it. So that lateral epicondyle is going to be there, right? And then you're going to line up both of your arms with that radiostyloid. If you want to get extension, you're going to come up and line up that straight arm with the midline of the humerus, right? Once you have it lined up, you're going to have the patient bend. What do you think this is going to line up with out here at the wrist? Your what styloid? What is my lateral styloid? My radial. Good. So midline of the humerus, lateral epicondyle, styloid process of the radius. The patient's going to move through. Now, when I move into elbow flexion, some of those bony landmarks might move. If they move, just readjust once you get them into full flexion, right? Sometimes, though, when you get up here into full flexion, you can lose that lateral epicondyle because a lot of times those soft tissues kind of push laterally and it's hard to find it. So you do have to palpate. Right, there's my lateral epicondyle. Right, so we're going to go off that and go off my radial styloid. I did put videos up for all of the range of motions for goniometry. And I also put up some good instructions on that as well on the Kinesis website. So here's functional range of motion. To use a phone. So let me tell you, here's what a phone looks like nowadays, right? Phone used to be attached to the wall. And we used to have to grab it off and it had a cord. And it used to have this thing in the middle that's called rotary that you could dial with, right? So back then, we actually needed somewhere between 40 and 135 degrees of flexion. Well, now we don't need it because we have a little friend called either Bixby or Hey Google, or I won't say her name because if I say her name, she's going to come out. Hey Siri, tell me a joke.
What do you call an apology written in dots and dashes? Morse code.
Ah, ha, ha. She's so funny. If you have kids, you can ask her to tell you a kid's joke too. She'll tell you kids' jokes. And the Wi-Fi tracks are red are great. But you may not need as much elbow flexion anymore, right? We used to have to hold a phone like this all the time, right? Now, if I want to make a call, what's wrong one? I can make a call like that, right? I don't have to have as much, motion in my elbow anymore to use phone. To open a door, you need about 24 to 50 degrees of flexion. You need to be able to pronate and supinate. So you need to be able to turn the doorknob. When you have a patient that's got wrist and elbow problems, we're actually going to do that as one of the activities. If you look in OT's therapy section, a lot of times they have a bunch of doorknobs mounted on walls so that people can sit there and practice turning doorknobs. Does that mean you can't open the door with a straight arm? No, you can. It just means you have to use your body to do it. Drinking out of a cup or a can, right? I need about 130 degrees of flexion, and I do need some supination because I need to be able to hold it so that my can's not dumping out. I call those 12-ounce curls. Sit to stand. You do need anywhere from 20 to 90 degrees of flexion to help push off, plus pronation. Your palms need to be able to go down. And then eating with utensils, right? Depending upon what utensil you need, you may need 85 to 130 in flexion, 10 in pronation, 60 in supination. So here's the good news. That is a lot of numbers. I'm not going to make you memorize these. Your boards more than likely aren't going to make you memorize these, but what they will say is something to the effect that the patient only has 10 degrees of elbow flexion. Which of the following activities will they have restrictions in doing? Opening a door, drinking a cup, sit to stand, all of the above. Your answer probably is going to be all of the above, right? Because anytime you have restrictions in elbow flexion, most of your functional ADLs are going to be challenged, right? And that's kind of a sad part is you lose elbow flexion, a lot of your life changes, right? Just look at anyone that has had an amputation of their forearm and hand. They lose a lot of the ability to do stuff, right? Think of all the stuff you take for granted that you use your elbow for, right? Brushing your teeth, washing your hair, putting my glasses on, right? If I don't have my hands and I have to kind of go, okay, let's see if I can do this. Not working, right? Oh, great. That really helped my glasses. So putting glasses on, caring for your kids, right? Changing diapers. I had that when I was when I went to Walter Reed. Believe it or not, those vets that came back, so vets being veterans that came back, one of their biggest concern was number one, when can I go back? And then the next concern a lot of them had was, am I going to be able to help my wife care for my kids? If they've lost an arm or lost a hand, something like that, it really hits home, right? It does. I will say that any of you that want to work in the VA, I applaud you. It's hard. When I did that rotation, that was probably one of the hardest things I've ever encountered. All right, goniometry we talked about already. Let's talk about manual muscle testing. So for manual muscle testing, there is a pronation and a supination manual muscle test. Excuse me. I put the information for those up, but you're not going to be tested on those. What you will be tested on at the elbow is elbow flexion and elbow extension. Yeah, the VA, we have contacts with the VA, just they're really picky about who they take. So maybe because you're like awesome and the chosen one, they'll take you. You never know. So elbow flexion. No, I actually wouldn't say that. Believe it or not, I would not even say it. Maybe a few years ago I would say that, Renee. But believe it or not, anymore, no. Mark's pretty cool, yeah. I wouldn't, honestly, Renee, I would say probably a few years ago, I would tend to agree with you, but nowadays, not so much. Believe it or not, a lot of they want you in the military more now because of that. I hate to say it, they do. Because you speak more languages than probably any American. All right, manual muscle testing. So manual muscle testing of the elbow. What position do you think we're going to test elbow flexion in? Yeah, seated. Good. Right? So right here, seated position. Right? So let's go through those manual muscle testing grades again. First thing you're going to do is you're going to show me the motion. Okay, great. That's what I want you to do, Mr. McKeever. Next thing you're going to have me what? You're going to tell me do it. Okay, so move through. You're going to watch to see if I get full range of motion, whether you're measuring goniometry or whether you're doing manual muscle tests. Same idea. Booyah. Great. Now I want you to pull up. Where are you going to put your force at? What do you think? Put force just by the right in the forearm, right? In which direction are you going to go? Down, right? I'm going to push down. Don't let me push you down. So now you get me in this position. So I do this. What's my worst grade right now? My worst grade I could possibly get is so I've got full range of motion against gravity, 3. It's the worst I can ever get. So now you get me here and you push me down. You're like 5, 4, now my arm drops out. Now I'm a 4, right? Now, let's say you do that and you're like, okay, ready, 5, and I break automatically. I'm still a 3. I didn't resist anything, right? But if I get 1, 2, and then break, 4. Now you're like, okay, ready, 5, 4, 3, 2, 1. Good job, Mr. McKeever. Now I'm a 5. Good. All right, so you tell me to bend my elbow, and I'm able to get here. What do you think you have to do next? I'm not able to go against gravity. So this is in which plane? This is in sagittal plane, which means you're going to put me in what position to eliminate gravity? Sideline. Good. So now you get me here. I had a few degrees against gravity. Now you move me on my sideline, and I'm like, yep, got it. You've eliminated gravity. Now I'm a what? 2+. You tell me to move with gravity. I'm like, nope. You move me on my sideline. I got full range of motion. Now I'm a 2. You get me sideline. I can't do full range, but I maybe get 90 degrees. Now I'm a 2-. Good. You can't see any motion. Where are you going to palpate on my arm? How are you going to palpate to see if I've got elbow flexion? Right? So you're going to want to get on the biceps and get around the biceps, because what else do you want to feel? See, I've got my hand, I'm kind of dug in. Because this way I can feel biceps contracting, and what else can I feel contracting? What's below the biceps? Brachialis, right? So do that right now. Find your bicep, kind of get your fingers around it, and then get it where you can feel under the bicep, and then bend your elbow. Can you feel brachialis sliding under biceps? It should just feel like something's kind of gliding right along your fingertips. You want to be able to palpate both of those, because what if the patient is missing biceps contraction, but we can get brachialis? We're going to see if we can work brachialis to substitute to get their elbow flexion. I got nice red marks on my arm. Probably going to bruise. And then 0, you got nada, right? No motion whatsoever. And again, if we've got 0 or even maybe a 1, I don't know that eStim's going to help. So let's take that a step further. you want to do Russian on my bicep. Where are you going to put the pads? You're going to put them laterally? Yeah, on that meaty part. You're going to slap them right across here. And if you can, get those big 2x4 rectangular pads. You know what I'm talking about? Do you guys see those? So the pads that are more rectangular in shape, because those lay across that bicep really nicely, and you can get a good contraction. You may even want to get one across biceps and maybe put one down here on brachioradialis, so brachioradialis can help you, depending upon what you're doing. But the best part is to think about where that neuromuscular junction is. So right here is my sensory signal, right? Right the mid part of that bicep, right? That's where my muscle spindle is. That's where everything is. And sometimes you can even kind of get in there, and if you dig a little bit, it's real sensitive, right? I can like doing that. If I go down here, it's not as bad, but if I do right at that mid bicep, it's kind of not, doesn't feel good. What you're doing is irritating that sensory cortex of the bicep. You want to try to get one of your pads right across that. So whenever you're working with E-stim, you've got to be thinking about where that muscle is, right? So if we're doing wrist extension, right? There's my wrist extensor wad, right? Most of my muscle is going to be up here. So I want to get one of the pads up here and then maybe one down here, but I want to get it right on that neuromuscular junction. So you've got to be thinking about that when you're putting the pads down, when we're strengthening muscles with E-stim, is getting them on those muscle bellies, right? Same idea if I'm working my quad. I want to get one right across that big hole. If I can, get one of the long ones that go right across my whole quad muscle, so that I hit all those neuromuscular junctions. All right, we'll start the wrist, and this is probably where we'll finish for today. Oh, God. Here we've got the wrist, right? We've got the radiocarpal joint. Why do we not have a radial ulnar joint? Well, the carpals don't articulate with the ulna very much. They just don't. They primarily articulate with our radius because the radius has the largest part down here. That ulna only has this little itsy bitsy part down here. So we've got our radiocarpal. We've got our midcarpal between the carpals. And then we have our carpal metacarpal joint, which is also known as our CMC joint. So this is kind of making up that full wrist structure down here. With wrist, we have both flexion and extension. This is also called palmaflexion and bolaflexion, or palmar flexion, dorsiflexion, right? But most of the time, you're going to hear this as flexion, this is extension. I don't know why we just don't go to universal terms. It just makes things easy, right? So here's flexion, neutral, extension, right? You have palmar and you have dorsal surfaces of your hands. Then we have radial and ulnar deviation, right? Radial goes to the thumb, ulnar goes to the pinky. And a lot, like me, I've got a lot of ulnar deviation, almost no radial deviation whatsoever. I think this hand I've got a little more radial, right? So looking at these, oh, here come the bones again, right? Scaphoid, lunate, triquetrium, pisiform, trapezium, trapezoid, capitate, and hamate. You can palpate almost all of these bones. It's really easy to find the pisiform because the pisiform kind of floats out here on the ulnar side, right? It's also easy to find. The hamate has a little thing that comes down like that. What's that called on the hamate? The hamate has a pointy part too. The hamate has the hook of the hamate. And that hook of the hamate you can palpate too, which is just going to be right up kind of above that pisiform. And then your capitate's the one that's kind of easy to find in the middle. That is the head of your hand. right? And with the head of your hand, that's going to allow for pulley systems to work. The trapezium and trapezium and trapezoid are over here. And there's our scaphoid. What is our scaphoid also known as? What happens very frequently with that scaphoid? Yeah, it's most broken when falling out on outstretched hands. Good. And if you look, if I fracture that scaphoid, could you see how easy it would be to fracture the radius too? If I fracture that scaphoid, it's coming straight back into that radius. The lunate, so these little ones have a habit of slipping out of place and subluxing. So sometimes you do have to kind of pop them back into place, but that would be a grade 5 mobilization. And what's our rule on PTAs and grade 5 mobilizations? Don't do them. Now, let me ask you something. Are you ready for this? What did I just do? I just did grade 5 mobilizations. Right? I just cracked my knuckles. That is a grade 5 mobilization. Right? We can do grade 5 how many of you do this? There. Where you get that nice crack in your neck. You guys do that? Anyone ever do that? Or where you're like, okay. Oh, there's the pop on my chest. What you're doing is a grade 5 mob there. Right? We can do that on ourselves. We can't do that on a patient. And I would never teach a patient to do a grade 5 mobilization. That just is asking for trouble. I'm just saying, right? But in the carpals, this is the other one. So long to pinky. Here comes the thumb. I didn't remember it that way. That is one way you can remember it, to go in a circle. I just remember the 2 rows, right? I'm sure you guys have that one down. But all of these bones are going to have ligaments associated with it, right? So here you have ulnar collateral ligament, radial collateral ligament. We have this disc in here. Does anyone know what that disc is called? Okay, let's see what this is. Does anyone know what that disc in between those ligaments is called? Has anyone heard of it before? It's articular, good. Has anyone ever heard of the TFCC? So let me get my stuff up here. TFCC. If you ever work in hand therapy, you're going to hear this a lot. Triangular fibrocartilage complex? Yes, complex. So technically this C is capitalized. So triangular fibrocartilage complex. It's this space here. Up there. It kind of goes right here. It's on the ulnar side, and this is a big chunk of stuff right in that ulnar side that kind of can pop sometimes when you move flexion extension. It's your TFCC. A lot of patients get problems with TFCC where this gets squished down and it'll cause them pain. So if that's getting squished down, what do you think we're going to do to relieve the pain? We're going to take these bones and we're going to move them away from the ulna. We're going to do what to them? What's that called when we move the stuff away? Traction. Yeah, we're going to do a little bit of traction. And some patients will be like, oh my God, that feels so good. So ligaments that we have there, we have our radial collateral, right? We saw that. We have our ulnar collateral. We saw that. We have our palmar radiocarpal ligament. So palmar radial carpal ligament, radiocarpal. we have our dorsal radiocarpal ligament. And again, they're named for where they go. Then we have that articular disc of the TFCC, and then we have our palmar fascia. What muscle attaches onto the palmar fascia? Palmaris longus, as long as you have it. Right? A good chunk of the population doesn't have it. So looking at this, right? So here's our radiocollateral. Here's our palmar carpal ligament, right? Here's palmar ulnar ligament. Here's our ulnar collateral ligament, right? And then over it, we've got, over top of all of this, we have our palmar fascia, right? And then we also have a little flexor retinaculum that lays over that all, that holds everything down to the palm. So there's kind of looking at it from the dorsal side. There's our palmar fascia, right? And when you open up the hand, when you see what's inside the hand, it's pretty complex. So muscles of the wrist. Well, we have our flexors and we have our extensors of the wrist, right? We have flexor carpi ulnaris, flexor carpi radialis, and palmaris longus. Those are all of our wrist flexors. Are those muscles intrinsic or extrinsic muscles of the hand? So flexor carpi ulnaris, radialis, and palmaris longus, are they extrinsic or intrinsic? Do you remember when we talked about that? So for it to be an intrinsic muscle, it has to start in the hand and stay in the hand. So all those muscles start up here, so that means they are extrinsic muscles, right? So intrinsic stays inside, extrinsics are exterior to wherever you're talking about. So if we're looking at the elbow, something like pronator teres theoretically is an intrinsic muscle of the elbow, whereas biceps would be an extrinsic muscle of the elbow. Does that make sense? But in the wrist, anything that's up here in the palm will be intrinsic. Anything that's past that is going to be extrinsic. For our extensors, we have radialis longus and radialis brevis that make up the extensor carpi radialis, and we have extensor carpi ulnaris. Now, if your wrist muscle is labeled carpi ulnaris, what other motion is it going to assist with other than flexion or extension? If it's labeled carpi ulnaris. Yes, it's going to assist with deviation to which side? If it's an ulnaris, it's going to go ulnar side. If it's a radialis, it's going to be radial side. So this muscle is going to work with this muscle to do ulnar deviation. This muscle is going to work with these two muscles to do radial deviation. Does that make sense? When they're labeled radialis, they help with radial deviation. When they're labeled ulnaris, they help with ulnar deviation because of the side of their arm. That's it. I hope you guys picked up on that when you were studying muscles of the arm and hand. But that's one that I've told people before, and they're like, oh my God, why didn't you say this before? That makes so much more sense now. Well, you got it now, and we'll just go with that. Here is our flexor, so coming from the flexor compartment or the flexor wad, going to the carpals on the ulnar side, right? So flexor wad to carpals. Here's our flexor carpi radialis. So flexor wad to our carpals on our radial side. Here's our palmaris longus, right? that comes because it helps with wrist flexion. It's going to start on that flexor wad and go down here to the palmar fascia. So start up here, attach to that palmar fascia. And then we'll look at the posterior muscles, right? We have our extensor carpi radialis longus, right? Starts from the extensor wad, goes to the radial side of the carpal bones, and it is long. Here's our extensor carpi radialis brevis. Starts at the extensor wad, goes to that radial carpal side, and is brief or short. And then there's our carpi ulnaris, extensor wad, to the ulnar side of the carpals. So looking at all of these muscles, so we're looking at the posterior aspect here of the hand, right? All these muscles are going to go down, and they're going to attach down to the hand. And when they attach down on that hand, they're going to be held down by these retinaculums. So when you're working with a patient and you're trying to palpate for them to do wrist extension or wrist flexion, there is no need to palpate below the mid-forearm. Because once you go below the mid-forearm, you're all tendon. There's not a lot down there except for some of the thumb muscles, right? So that means if you're going to palpate your muscles that are moving the wrist, you've got to go mid-forearm and proximal. That's the only way you're going to get a hold and feel those muscles. These retinaculums, which is what I've talked about before, because you have an extensor retinaculum, and I think when we get to the other side, you'll have a flexor retinaculum. The job of this retinaculum is you have all these tendons coming down through here, and you have a bunch of nerves on the other side and blood vessels. The job of the retinaculum is to hold all that down to the bones so that one of these tendons doesn't slip free. The other thing that retinaculum's doing is it's creating a pulley system, right? Because you can just imagine this being a wheel here. And now when extensor carpi radialis brevis pulls, it's creating a pulley system, giving us greater mechanical advantage. And here's our flexor retinaculum, the only muscle. So if you ever get a question on your boards that says, what is the only muscle that does not go under the flexor retinaculum? The only muscle that doesn't is palmaris longus, because palmaris longus goes over it and attaches to the palmar fascia. How many of you guys have heard of a, so first of all, what's it called when you get, your hands get sore from being in this position again, from typing? What tunnel are you compressing? Carpal tunnel syndrome, right? How many of you have heard of a carpal tunnel release surgery? So CTRS, carpal tunnel release surgery. Has anyone heard of that? No? Okay, some of you have, good. So when they do a CTRS, what they're going to do is they're going to come in here and excise that retinaculum. Or if it's not totally, compressed, they may excise half of it or a third of it or whatever they need, but they're cutting out that retinaculum. What that job is, if I cut out that retinaculum, I open more space in the wrist to allow for those nerves to pass, right? The downside is that retinaculum is there for a purpose, right? That retinaculum is there to hold all that stuff in place. And now I cut it out, and the only thing really holding it in place is maybe my palmaris longus if they didn't cut that out too. And so now all those ligaments and all those nerves and all those blood vessels and all those tendons have free reign in your carpals. And a lot of times those patients may come out with more pain. And not only that, but let's put scar tissue down here right at the wrist and think of how well that's going to work out. All right, so let's call it here. We'll give you your break and cut you loose. And then we'll start tomorrow with open and close pack to the wrist and kind of talk through the motions of the hand. How does that sound? Stop share.